Welcome to this Fireside Chat on inclusive healthcare. We planned to introduce ourselves, what we are doing, and then ask between us what could be interesting. And I think if there are urgent questions from the auditorium, we want to embed it because it is always good to have some interaction. So perhaps let me start. I'm Johannes Fellinger. I'm a neurologist, psychiatrist, and child neurologist, having been working in serving deaf people in healthcare since the early 90s, but also setting up clinics for people with complex disabilities, with multidisciplinary teams, always based in hospitals to use all the facilities. So the specialized services is one side, and the other side is, of course, to promote accessibility in general. So that is a very brief introduction what we're actually doing. And now I hand over. Please introduce yourself.
Thank you. I'm Jennifer Ria, and I serve as the Chief Strategy Officer for I Am Boundless, which is based in Ohio in the United States. And I'm very excited to talk today about our Boundless Health Clinic, which is an integrated outpatient setting that includes primary care, dentistry, psychiatry, behavioral health, and speech-language pathology services. And the thing that makes it unique is that in the United States, the rest of the world really sort of builds for the general population, but then says, oh, well, people with disabilities can come too. But it's not built for them. It's not created with their needs in mind. And we really did the opposite. We created everything and started from the foundation, building around the needs of people who are neurodivergent, people with disabilities, people with behavioral health conditions, and then said the rest of the world can come. And amazingly, as we've built this, it's almost become 50-50 of people with disabilities and people who don't have a stated or acknowledged disability using our health services just because they're great. And we find that universal design is attractive to all humans.
That's a very interesting contrast. We are also, actually, we have a quite similar scope. We serve people with complex needs, and therefore we have a concept of health, including physical health, mental health, social health, and using all the disciplines of the hospital. But we created that safe space with specialized colleagues who have extra time and training to really focus on the problems our patients with disabilities have, let's say on cerebral palsy or complex epilepsy, or the clinics serving deaf people, competence in sign language, but also much more than only sign language. So we are not allowing mainstream population to use those facilities because they would easily flood us.
Yeah.
How do you handle that?
You know, you point out two really important things, and one is the extra time that's needed.
Yeah.
And in the U.S., with the way healthcare is funded, it's a time-based system or it's a code-based system, and you don't necessarily get paid for more time if you go beyond a certain amount. So that's very, very challenging. So at this point, honestly, I think not a lot of people know about us. And the more people that know about us, the busier we get. Because you're absolutely right. When people realize, oh, these doctors, not only are they specializing experts, they're going to spend extra time. They're going to really, really spend the point to connect at the human level. But yeah, at this point, honestly, we are not yet overwhelmed because we're relatively new.
Okay, but that will happen. So I warn you really to keep that space protected. We have to negotiate hard with the governments and health insurance to give that extra time and to pay the colleagues who are able to specialize. And really we have to defend this space because medicine is under stress everywhere.
That's true.
And time is money for many doctors. And so if we don't have the preferred, but not luxury, but necessary extra attention, the majority will take over.
You mentioned about the specialty, and we were talking about this before we started, and I was commenting on the fact that in the United States, in most healthcare disciplines, there is not a program in, the graduate training in medical schools, in the different programs to actually specialize in understanding the needs or serving the needs of people with disabilities, and how challenging that is, because essentially we often are in the place of creating our own experts. That we're hiring people who come with their expertise and maybe a passion or an interest in serving people with disabilities, but then we have to create those experts. And it sounds like maybe that's different here.
It starts to improve. We have now a curriculum accepted by the Medical Doctors Association to promote the skills of doctors from different disciplines to serve people with disabilities. That is quite brand new. In Germany, they have that for a longer time, and they have health centers for deaf people, even by law, which is quite unique in the world.
Yeah.
And I know in the US, there's one association of American neurologists, very small, who are interested in the field, but they are not running clinics. And what I liked when I saw your project, that you are multidisciplinary.
Mm-hmm. Yeah, we really find that the integration is key and critical, because so many people with disabilities need to see lots of different aspects of healthcare, and at least in the United States, and I think this is pretty universal, often the different specialties are very siloed.
Yeah.
And coordinating between them and accessing the different kind of care is just a huge burden on families, a huge burden on people with disabilities to navigate that. So by bringing them together, it's really transformational for so many people, and being able to not only access it easier, but then have all of those providers, all those disciplines talking and collaborating and making sure that we're all collectively seeing the whole person and thinking about the big picture. It makes such a huge difference.
Even the topic how to bring one person with a very stressful reaction from one to the other is a challenge. So for me, one of the metaphors is Formula One. When the car is coming in, all the technicians put the wheels and fuel and everything in check. And that is how we have to serve, not stressful, but gentle, but to use the person being present and work around the person. Is that happening with you as well?
It is. I have an example of that you reminded me of with the Formula One analogy. We will often have people coming in for a dental visit.
Yeah.
And so we do non-sedation dentistry, but in order to do that with many people with disabilities, that we are probably their first time getting dental care, or certainly without sedation. And so we have to develop a pretty deep rapport and relationship with people for them to trust us to do dental care. And so it is not uncommon that if the person is there for dental care and we're checking the person's total chart, we realize they're due for their flu vaccine. Oh, their psychiatrist needs a blood draw to do a med change next week. Like, let's do all these things while you're here. You're with people you know. You don't need to come back. And coordinating all that together, it makes such a huge difference.
I'm very happy to hear that from you as well. And I think we have one discussion all over the places. Why do you have special units for people with disabilities? Everywhere should be possible anything. How do you argument on that?
Yeah. I don't argue that it shouldn't be, but I argue in the world that is. We look at the data. We see that people with disabilities continue to, on average, die 20 years earlier than the general population, and it's not because, in most cases, of the medical conditions. It's because of the lack of access to preventative care and quality acute care by people who understand.
Definitely.
And so, given what is, the response has to be, then we need to create a world that does something about it.
Mm-hmm. Exactly. Other questions from you? If not yet, we can continue our discussion, but I think it's always good to have all people on board. Do you also evaluate your outcomes?
We do. So we We evaluate outcomes in a lot of different ways. So we, interestingly, have a number of different research projects that we collaborate with universities on, that we collaborate, in some cases, actually with payers on. We've been running a project that it's around assessing suicidal risk and suicidality in all patients. And going into it, the project essentially had no data with regard to people with disabilities, and really it was sort of we have no idea if there's any difference. And what we have discovered in this project is that many of the people that we are serving, and in some cases had been serving for a long time, we were not catching and were unaware of the fact that some of them were struggling with depression and were struggling with some of these thoughts. And so we track outcomes a number of different ways. Then we also are tracking health outcomes. We use a very structured approach for skill building in our dental clinic to help people acquire the skills to be able to tolerate non-sedation dentistry. And so all of that is very data-based, very focused on tracking and helping in some cases actually create the evidence-based models because they're just not out there.
We are now having a study with health economy, and the first results are showing it is even an advantage economy-wise to have this focused service. Less inpatient intakes, less investigations.
Absolutely.
So I think we have a very good health economy department at our university to check for that, because this could be a good argument for public funding.
The amount of things that we are going to catch and be able to address on an outpatient basis and in a preventative way that otherwise would have resulted in hospitalizations, would have resulted in emergency room visits. Yes, absolutely, you're right, that it has an economic impact.
Do you have a special program for Down syndrome adult people?
We serve people as young as 2 all the way through the end of life, but we don't have a special program just for people with Down syndrome, but we do serve a lot of people who have Down syndrome, especially in our primary care program.
What we found, many people who have Down syndrome have no regular health checks.
Yes.
And though we established a health check compendium, which we actually plan with the patients, and that's quite successful. To put it on a regular base, and they come and they have their checks, which are not available sometimes.
That's really the case, I think, with a lot of intellectual and developmental disabilities, is that many don't have a relationship with a primary care provider in the way that all of us should. That they just haven't been able to find someone who is a good fit, who wants to see them, who understands them. So absolutely, that's a challenge. I'm also interested in hearing how you address physical plant accessibility and some of the things that you've done or tried to make sure that the setting is, really accessible.
We are in the ground floor, which is very good, and the unit is quite accessible. Mm-hmm. Do you also have signing doctors who do it themselves? That's our main thing. Is we always try to have medicine under 4 eyes. The professionals who sign for the deaf, without interpreters, completely private. So we have to train a lot, but I think that's very important to give the dignity of privacy, even for people with complex disabilities. Sometimes they are alone with the doctor, if possible.
That's fantastic. We don't have any providers who sign. So kudos, that's amazing. We do use both live or virtual interpreters based on what people are comfortable with, but we don't have any providers who they themselves sign. That's fantastic.
Yeah, you see, this is just, we are discussing, we could continue.
Talk for hours.
But the watch is telling us there are only a few seconds left. So just to finish that, I think we will be around here a little bit, or in the back, not to disturb the next fireside chat. And if there are ideas to discuss, I think we are in the back. And it's only interesting to see how these special approaches emerge from based on the needs of the people, and how difficult it is to make them sustainable, although it is a logical thing, actually.
It is. Thank you so much. This has been so much fun.
Thank you for coming.